Hello, everyone. My name is Isabella Johnson, and I lead HPV education and programming at HPV Cancers Alliance. We are a national nonprofit committed to reducing the burden of HPV and related cancers through comprehensive education, prevention, and advocacy. We're here today with Dr. George Lowe, a head and neck cancer patient, and Dr. Nishant Agrawal, a head and neck surgeon at the University of Chicago Medicine. It's a pleasure to be with you both today during Head and Neck Cancer Awareness Month, and I'm excited to dive into this important conversation. Jumping right into this first segment on really what is HPV and how does it cause head and neck cancer? These questions are for both of you. For someone hearing this for the first time, what is HPV and how does it actually lead to head and neck cancer?
So HPV or human papillomavirus is an extremely common virus. Most people are exposed at some point in their lives, and then most people clear the infection. In a very small subset of individuals, there's a persistent infection in the oropharynx, which is essentially our throat, like the tonsils or the back of the tongue. And over time, with certain high-risk strains, like especially HPV type 16 and 18, this can lead to cancer.
And George, before your diagnosis of HPV positive head and neck cancer, had you ever heard of HPV being linked to head and neck cancer at all?
Yes, I had. And actually, prior to this, I worked with the New Jersey State Department of Health with their HIV, STD, and TB services. So we were concentrating on infectious diseases for sure. And although I wasn't aware of the rate of incidence with men at all, and prior to working with the State Department of Health, I did open a brand new FQHC in New York City back in 2005. And I remember our protocol was, of course, women who were sexually active had to have a pap smear every 2 years, right? And so I remember someone going to the medical director at the time saying, well, I'm a lesbian and I've only ever been with a woman, and why should I have to have this pap smear? So when he was putting together his protocol, he was like, well, yeah, you're right. I don't see the need for it. But then we found out later that it wasn't just transmission that way. So it's been this progression, right, of it doesn't have to be, vaginally from a man. It's a virus. And so anyway, it's been evolving. But again, I was not aware of the incidence. I know Rutgers did a big research project about 3 years ago with anal HPV. And reaching out to all of us in the field about getting fluoroscopes for people who are high risk. But again, not hearing of it with all the populations I work with.
Thank you. I'm even having that jumping off point. It can be very complex and layered, and thank you for your public health work. Moving into early signs and a path to diagnosis, George, what were the first symptoms that you noticed, and what made you decide to seek care?
Sure. So I had a lump here in my neck, but I've also had cysts in the past where I've gone to my dermatologist and they're cysts. And so I assumed that it had something to do with my beard, maybe. And so I had steroid cream at home from my previous cysts. I would put it on and I was like, okay, it looks like it went down. And then I was like, it's not going down. And I actually was squeezing it, thinking that, it was very cyst-like. And finally I said, no pain, no nothing. But I probably need to go to the dermatologist and have it looked at. And she was great. She felt it. I told her I wear a sleep apnea mask and it goes across that region also. And, with the beard, and she said, it could be, but let's get that ultrasound. And so she ordered an ultrasound, and I've had several in the past, and they were always like, okay, the doctor will get back to you. But this time she said, wait here, I'm getting the doctor. And I was like, oh boy, That has never happened. So the doctor came in and he said, this is definitely your lymph nodes. You're going to need a fine needle biopsy. I can do that for you. And I was like, whoa, whoa, let me go back to who referred me, dermatology, and we'll take it from there. But again, he had said, have you had any vaccines lately? Have you, had any types of virus or whatever? Because this is definitely a lymph node. And so I went back to the dermatologist who said, I'm going to refer you to an ENT doctor. Because that is who we would refer to now that we know it's lymph node. So I went to an ENT doctor, and again, the same thing, pain, swallowing, trouble, no, 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 no. And so he right away ordered a MRI, and then, of course, that lit up showing the area. And then he ordered a PET scan, and then the fine needle biopsy, because now they knew the areas and everything. So when I got the results of the fine needle biopsy, it said positive for squamous cell carcinoma metastasized to neck. So you can imagine what was going through my mind. And it did say P16.
Mm-hmm.
And so, being a licensed social worker in the medical field, my doctorate in integrative behavioral health, of course, Dr. Google and AI, I found out that if you're going to have a head and neck, this is the one to have. And so that sort of de-escalated, and then for me, and then that led me going back to my ENT, who now referred me to an oncologist. And I can get into that later, what happened, but was my process up to that point of finding out and steps you have to go through.
Dr. Agrawal, based on George's experience, what really are the most common early warning signs that patients should look for, and at what point should they seek evaluation?
Yeah, so George's story is not uncommon, and we get referrals from dermatologists because patients present with a quote unquote skin cyst. But really, the most common signs are so subtle, right? As George so eloquently described, the persistent sore throat, he didn't have it, difficulty swallowing, he didn't have it, hoarseness, ear pain, none of it, but he had a painless lump in the neck. Which didn't go away. So these are often ignored or mistaken for sort of benign conditions, including skin cysts, and that can cause delay in diagnosis. So time matters, though. It's cancer. So if a symptom or a painless lump in your neck lasts more than a couple of weeks, or you have persistent symptoms such as throat pain or swallowing difficulty, it should be evaluated. Head and neck cancers are highly treatable when caught early.
Good to know. Awesome. So, going off of that, from your perspective, how do tools like telehealth or at-home screening options help bridge gaps in early detection?
Yeah, access is a major obstacle in healthcare, and telehealth provides improved access and helps us triage patients, helping patients enter the system earlier. At the same time, there's emerging diagnostic tools, including saliva-based assays that are being developed that detect cancer-associated changes earlier and in a non-invasive way. So we're moving towards a future where early detection can be simpler, faster, easier, and less invasive.
That's very encouraging. So, based on what you've said and your story and experience that you started, George, can you walk us through just the moment that you had received your diagnosis and perhaps the most challenging part of your treatment journey, physically or emotionally?
Sure. So again, back to my ENT saying, who's your oncologist? And I was like, I don't have an oncologist, and so he referred me to a group that he works with at a hospital near where I live. And now, in the meantime, I'm doing all this research, right? And I'm seeing all these clinical trials that Mayo Clinic had done several years ago, which shortened radiation times. And, the outcomes of those trials at 5 years. And then I was finding out the difference between the P16 and the non-P16. And because I kept hearing, if you're going to have one, it's the best one. So I was like, okay. So I went to the meeting with the oncologist, and there was a team there, a nutritionist, a nurse, a pain management person. And I was sitting there, I had my water bottle in my lap, and they were saying, we're going to have to radiate you 5 times a week for 7 weeks, and you're going to have chemo every day for 7 weeks. And if you lose more than 10 pounds, we'll put you on a feeding tube. And I'm like, whoa, I thought I had the better one. And so I'm listening. And then I said, will I be able to work? And they're like, no, you. And I was like, so I left there, very concerned and confused because of what I had read with the trial. So I took it a step further after I left, and I did more and more research, and I found out Sloan Memorial was doing a clinical trial. Now, I know the Mayo one, I believe, had an 80% success rate at, say, 5 years, which you say is great, but 20% had failed it. And they know with the traditional 7 weeks, it's much higher. It's like 99. And so I guess Sloan now had put in that we would add another week of radiation in this clinical trial, and then we would do the same number of chemos. So I applied for that clinical trial, and I got it, and I got in. And of course, when I read the information, it had said that I think there were 80 people that had signed up for it, and they were going to randomize 50 into a 3-week trial and then 50 into the 7-week. And so from everything I had read, I wanted to avoid that 7-week, like anything. And I was like, really. And I actually called them and said, when I read the data, the research, I said, can I pull out if I'm at the same place as everybody else? That was 3 weeks. And they said, you can pull out at any time, but we don't recommend it. And so I was like, all right, well, let me just see how this works out. So I went back to my ENT, and I did say to him, why did you refer me first to an oncology surgeon and radiologist without talking to me about the options, because this is so specialized and different? And he knows I have my PhD and everything. And he said, where's the data, George? They're not publishing it. How come it's not out there? And I said, what do you mean it's not out there? I found it. Everybody, what's working, what's not working. So I said to him, I said, look, I'm going to go to Sloan. Please tell the tumor team that was my choice, and that's what I'm going to do. So a week before I was to start the clinical trial, literally a week, that oncologist called me and said, I just want to let you know you're still in our chart. We can take you at any time. And I was like, I thank you very much, but I decided to do the trial. And he said, yes, I know Sloan. He said, I fix a lot of their patients. And I was like, okay, well, I hear what you're saying there. Again, health vice president of ambulatory care at St. Clair's for 15 years. I know the whole thing. And so I said, well, with all due respect, I'm going to go with this. And then before he hung up, he said, I just want to let you know, we talk in this field. I have colleagues. And that Mayo Clinic trial, it failed. It failed, George. And I said, I'm well aware of that. I'm making this decision, I'm based on what I believe is the best option for me. And I was really annoyed that a week before I was doing this, that he was putting this in my mind, But anyway, again, because of my background, he didn't really understand who he was talking to. And so anyway, I started the trial, and again, this is where that integrated behavioral health piece, where which is my doctorate, right? This is a doctoral program at Arizona State University School of Medicine. And it's saying you can't have healthcare without integrated behavioral health, right? And so you're going in a clinical trial, and there really wasn't that piece. They were very concerned about people staying in the trial, right? And getting the outcome that they have for their hypothesis, right? And so they knew where I was coming from. So after 3 weeks, we were all going to be, we all had to go to Sloan and have a scan. And if it lit up, you stayed in the trial. If it didn't, whoever was randomized at 3 weeks, they were done. That was it. 3 weeks of radiation and done. And as I was going through my 3 weeks, I kept hearing, keep your fingers crossed that you're lucky that you get in the three. I'm looking at your chart. There's any indication that you're going to be randomized. We just don't know. And, we know the radiation's starting to kick in. It's 2.5 weeks. This might be the last of it for you. And so you're going along with that, right? And then I get that phone call. You've been randomized into 7 weeks. And I can't tell you, because the way it was set up about being lucky, I now felt unlucky, right? Mm-hmm. Just because some computer randomized me, I am going through the most brutal next 4 weeks, that I was so not wanting to do. And so I did reach out to the head of the clinical trial, and I said, I'm at the same place all the other people were, the other 35 and whatever, and I want to pull out. And I literally got a phone call 2 minutes later. You're killing me, George. I can't believe this. What are you doing? And I said, I'm 63 years old. Let the 50-year-old do the 7 weeks. Like, you're not now I'm just a number in this, that has been randomized. And she assured me that I would be, that they were not doing what they would traditionally do. They would do very focused radiation, and that I should start to feel better in the 4th week, because they were dropping the radiation. And so I was like, well, if you say I'm going to feel better, I'll do it. Well, that wasn't the case. And then the radiologist told me, you're not going to feel better for weeks. Radiation is stacked. Even if they did change it, and now it was getting worse. Of course, the mucus, the phlegm, everything out of control. I lost the day, my blood sugar, everything. And so I completed that week, and then I realized I wasn't feeling better, and I said that I was pulling out again. This time, the oncologist, it was the oncologist, not the radiologist, sat me down, and he said, George, I'm going to explain something to you. He said, if you had gone to that hospital, they would have given you 70 rads of radiation everywhere in your mouth. You all got, everyone for the first 3 weeks, 50 rads, and pinpoint it. And I'm sorry, just to regress a little here. They could not find from my MRI or my PET scan the source. It was not lighting up anywhere. What metastasized to my neck was, for sure. But, and so they had said to me, we're going to have to find the source as part of the clinical trial, because we're going to pinpoint that source. So we have to know it. So I went in and I met with a surgeon. And, he looked and felt around everything. And he said, look, I'm going to biopsy your tonsil. If it's there, we know the source. If it's not, we still have to find it. We'll have to take that tonsil out. And I was like, wow, you are so adamant about that. So anyway, when I had met with the doctor at the hospital, he said to me, because he said, well, don't worry about it. We're not going to biopsy anything or whatever. We're just going to radiate everything at 70 rats. And so when I'm meeting with this doctor, he said, right away, you got less than everywhere, right? and now you will be pinpointed. And he said, as an oncologist, I usually don't get into this because this is radiology, oncology, but I'm going to with you. And he said, so you got 50 rads for 3 weeks, then you got 2 weeks of 60, more focused, and your last 2 weeks are 70, but pinpoint. And so I said, oh, I'm not at the same the whole time, and I'm actually, the biggest part is the last 2 weeks. And he was like, yes. But I was still, I'm telling you, I was like, no, I'm done. I did more than a lot of other people. And I said, look, I feel like I'm failing this treatment. And I feel like you're not patient centered. You're more, at this point, clinically trial centered, and he said something to me that really upset me. He said, if your cancer comes back, you have no one to blame but yourself. And I said, whoa, did you say that to the 35 people who got randomized at 3 weeks? Congratulations, you're lucky. And if your cancer comes back, you have no one to blame but yourself. So you see how that whole behavioral health part, this doctor shouldn't be spending this much time with me at this stage of the game. This should have already been discussed. And so what his biggest concern with me was my age, and that if it came back, the treatment would be so much more worse. So it wasn't about the numbers for the clinical trial. He's just like, in a sense, George, it's good you did get the 7 weeks because it had metastasized and everything. And so I had said, and he goes, and you're not failing chemo. You have the kidney function of a 19-year-old. Like people who are failing are in the hospital. Yes, you have terrible ulcers. I lost 40 pounds, all of that. But so anyway, and he said something at the very end that made me say yes. I put my head down, and he said, George, you are a lot stronger than you think you are. And I just took that to be everything, the universe, everything I know, everything and I said, okay, I'll do it. And I did it.
Wow.
But I had said to him, and I said to them after, their whole social work department and everything, that doctor really only had 15 minutes with me, right? And they ended up spending so much more time than was necessary. And I think they were afraid to say to the people coming in, well, if you do get 3 weeks, there's a chance, because we don't know, that it can come back, instead of be lucky. Do you see? Like, all of that wasn't explained. So that's where I look at now, where my position that I'm in, all this has happened. Why did I get my doctorate in this field? My healthcare background, everything I've been through. This is why I reached out to the HPV Cancer Alliance. I am making this my mission, that if somebody gets HPV head and neck and they Google, and they'll see Dr. George Lowe in my picture there at some point, because it's, I understand both sides of it. I really do. But it is complex, and clinical trials are complex. And so, doctor, if you want to, now that you've heard my story.
No, I appreciate the personal story, George. Yeah, it is complex. Just a few clarifications. So nationally, the cure rate for HPV-associated oropharyngeal cancer is about 85%.
Oh,
And
okay.
George, you're absolutely right. There have been some negative trials, but there have also been some very promising trials that have reported their data with sort of 90 to 95% survival, including some of the work we've done at U Chicago. So I think there are some very successful clinical trials for de-escalation. And I know you sort of had this experience that you described, but clinical trials generally are designed very carefully, very thoughtfully, to really optimize patient outcomes and really be patient-centered. But yeah, I think, as George mentioned, have these discussions with the oncology team, and I think a lot of these concerns can be clarified. But I think a really important point that George also made is, even with de-escalation clinical trials, I think, and the overall significantly better prognosis, patients and physicians still underestimate that treatment. And it is intense in duration, and it is affecting very sensitive areas in our body. So even with excellent cure rates, therapies can still significantly affect speech, swallowing, voice, nutrition, and quality of life, both short-term and long-term. So in terms of the treatment, I think George highlighted everything. The treatment has definitely evolved. There's been significant advances. There's been more precise radiation with smaller fields, better surgical techniques, newer sort of chemotherapy and immunotherapy, which have come into play and are under investigation. And again, there's a huge focus, a major focus on de-escalating treatment in HPV-related cancers while maintaining oncologic outcomes, but reducing long-term side effects. So really the goal is not just to cure, but to preserve function and quality of life for many decades beyond.
Yeah, that was the one thing that he had said to me too that time. He said, George, really the achieving goal here is to protect your swallowing.
Yeah.
This is whether you were 3 weeks or 7. We're saying now, because we're pinpointing, we reduced it. And so as part of the study, I had to do swallow tests before I went in, to see before and after, if then again, the lower dose in the beginning, and to your point. So it wasn't about really shorter, or longer this clinical trial. It was really to say, can we preserve the swallowing? And so, like you said, for the long-term effects.
Perfect. Well, that was really an incredible, example of self-advocacy, and Dr. Agrawal, touching on how intense the treatment can be. We really want to focus on prevention. And if I can segue into who is at risk in a public health perspective and patient risk perception, Dr. Agrawal, who is most at risk for HPV-related head and neck cancers, and are we seeing shifts in those demographics?
Yeah, definitely. So many patients do not fit the typical cancer profile, and HPV-related head and neck cancers does disproportionately affect men, often in their 40s to 60s, and many of them who do not have the traditional risk factors like smoking. And that's why this forum and awareness, both at the physician level, it was great, George, that your dermatologist didn't just brush you off, and also at the public level. And why these rates are rising, especially in men, we don't really know, but we think it's sort of multifactorial. There's probably differences in exposure. We think that it is thought to be related to oral sex and number of sexual partners. And historically, vaccination rates have been lower in boys compared to girls, though that is improving. So I think the rising rate is entirely preventable. And that's why, again, this discussion is so important that we can address this public health issue that we're all facing.
Yes, and on the topic of discussion and having the actual conversation, there's often a stigma and misunderstanding around HPV. So how do we shift to a more productive conversation when we talk about this cancer-causing virus?
George, do you want to go, or I can go?
Yeah, sure.
Yeah, I can start, and then I'll let you add on.
Sure. Yeah.
So, HPV is one of the most common viruses in humans. Nearly everyone is exposed to HPV at some point in their life. And in most cases, the body clears the infection naturally. So this should be approached like any other infection, any other virus infection, like the flu, but it has a cancer risk associated with it on the tail end. So removing that stigma really allows us to focus on prevention, vaccination, and early detection.
Yeah, so I think I shared this earlier. When I was sitting there every day for my radiation treatment at Sloan, the poster in front of me every day was the only preventable vaccine against cancer. And I'm sitting there with abscesses on my tongue, mucus phlegm, being strapped in this, cage to do my radiation. And I kept thinking, I miss that. You know what I'm saying? And then I know in the field, they say if you're over 45, they won't even do it. Like insurance won't even pay for it. Like you've been exposed, you got to wait and see if you're one of the ones. So yes. And then again, the clinical trial too was to say, because these numbers are so high and what's coming down the pike is going to be really very high. What we're doing now is helping that generation not have to go through everything that a regular traditional head and neck cancer patient would have to go through. So if they end up at the end of the day saying we have the same effective rate in treatment with 4 weeks and just 2 of this, right? We've helped so many people. So my message to everyone out there, and now of course I'm familiar with the Gardasil commercials that we all see when we're watching TV, and I noticed the age dropped from 14 to 9, I believe now. And so I think that should be very clear to people. This is a virus and we need to get it very early on. And so and just speaking with people, I know when it first came out 15 years ago, a lot of pediatricians would say, look, if this were my kid, I wouldn't get it. It's too soon. It's too whatever. But that was then. And we need, and so a lot of parents made decisions on that years ago. And it's, there needs to be that other part that it's the only preventable vaccine against cancer. We're not talking about flu. We're not talking about pneumonia. We're talking about cancer. So I think a lot of public service announcements, a lot of really, seriously, with the early days of cigarette smoking, you had the people who were dying of lung cancer, and, and I did see this one statistic, and let me know if it's off, but it said 1 in 180 men between the ages of 50 and 64 will have HPV head and neck.
Yeah, it's estimated to probably be about 30 to 50,000 cases in the United States. Our population, someone can do the math, but our population is like 300 million. So
Yeah.
Yeah. Well, nonetheless, George, you're right to the point. We have the tools. With vaccination and early detection and screening, we can prevent these cancers. And Dr. Agrawal, I know that as a surgeon, you're seeing late stage disease, but as a physician, how do you recommend the vaccine and how do you talk about it with patients?
yeah, so the vaccine is now approved for adults less than 45, and that age has slowly increased over time. And essentially, you want to get it before exposure. So it is up to 45. And when they increased that age, I got my vaccine when I was still eligible. So the vaccination is really the most effective prevention strategy that we have. The HPV vaccine is safe, it's effective, it dramatically reduces the risk of HPV-related cancers, especially when it's given before any exposure. So really advocate for vaccination.
Wonderful. Well, thank you both. We've gotten to so many important discussion points in this area of disease prevention and treatment. So I will move to our closing question that I will ask to both of you individually. What is one piece of advice that you would give to save someone's life when it comes to HPV positive head and neck cancer? So I'll let Dr. Agrawal start, and then we will conclude with you, George.
Sure.
So get vaccinated, pay attention to persistent symptoms, painless neck mass, chronic sore throat, seek early care to facilitate earlier diagnosis. And unlike pap smears for cervical cancer, we don't really have a standardized way to screen for head and neck cancers, which is why awareness and early symptom evaluation is really critical. And there are also emerging approaches like some of the blood-based and saliva-based assays that are very promising. So because these areas are sort of accessible, we need to do a much better job with earlier diagnosis. But again, prevention is key. Get vaccinated.
No, absolutely. And for those who it was too late for, really stigma is, probably one of the biggest things that people might be, again, HIV or anything STD related, around stigma. I know with the HIV, with the HPV Cancer Alliance, a woman went to her doctor and he said, well, you have anal HPV because you had anal sex and I never have. So like you got it because I mean, again, it needs to be, there's no cultural competency here for physicians. It is what it is. It doesn't discriminate. It doesn't, to your point, everyone is exposed to it. Where it lands, we don't know. So I think it's just really important to get that message out there for those, again, yes, we vaccinate for sure, but don't let, some people have let their, especially with women, HPV anal, get to the point where they do die from it. And we know famous people who have, and so, we need to tackle it from both perspectives. And again, because it's like, well, if I got it from someone, did I give it to someone? And there's just so much, again, that behavioral health piece that always needs to be addressed.
Absolutely. Well, thank you both so much. I think that you've made clear the importance of discussing HPV out loud, talking about head and neck cancer in this space, and encouraging innovations in early detection. So, Dr. Agrawal, Dr. Lowe, thank you so much for joining me.
Thank you
so much, Isabella.
Nice meeting you, Dr. Agrawal.
Same here, George. Thanks.
Sure.
Thank you both.